Hello everyone. This is a very hard brown cataract planning for toric implantation, Tecnis Toric. So challenge is that the patient has a very narrow palpebral aperture. After marking the reference marking under slit lamp, now I am marking the excessive placement. Actual placement is 167. So as it cannot be marked, so I am marking the 165 degree on both the sides. Side ports are made with MBR blade, angled MBR blade. Intracameral lignocaine is used. Tryptophan blue is used for better visualization of the lens, entry lens capsule. AC formed with viscoelastics now. And then as the incision has to be placed 180 degree, I am doing it with your 2.8 keratome, removing the air bubble from the antechamber, putting viscoelastic over the cornea for better visualization and magnification. Starting my capsular axis through the side port with 26 gauge band cystitome. My plan is to do a capsular axis of around 4.5 to 5. Should be well centered. Our axis got completed. So removing now a little bit of viscoelastics from the antechamber before proceeding with hydrodissection. You can see the fluid wave depressing so that the fluid will come out from behind. Again forming the chamber with viscoelastics. Checking for nucleus rotation. The nucleus is freely mobile now, which is a very crucial step. So here I'm using very long chopper. I'm doing a sculpting now. Before that I'm removing some of the superficial cortex so as to expose the deeper endonucleus. Doing a short and deep trench so that I can bury the tip deep inside for chopping. The power I kept at around 80%. So now I am preparing for chop, vertical chop. The Phaco tip has impaled the nucleus deep inside, and the sharp chopper is used to crack the nucleus. First time it got slipped, I increased the vacuum from 400 to 425 to have a better holdability now. So now I could chop. So similarly, the nucleus will be chopped of around 6 to 8 pieces. Making sure that the pieces are separated from each other, especially the posterior plate should be separated. Now injecting dispersive viscoelastics so that it will protect the endothelium. Doing quadrant emulsification now. Each pie will be held and then it will be brought to the safe zone at the center and will be emulsified. Here I have kept the flow rate a little bit on the higher side so that the pieces will be attracted towards the phaco tip for better followability. And here we don't need a very high vacuum as we need for chopping. So each nucleus will be emulsified one after another. If any bigger nucleus, it can be sub-chopped as you can see here. And making sure that the phaco probe remains at the center, it doesn't go to the periphery to chase the nucleus pieces. Rather, one should use the second instrument to feed the phaco probe. Removing some of the chips which are there at the side port. Now it's the time to do biomineral irrigation aspiration of the cortex. Polishing the undersurface of the lens capsule, switching my hands. Polishing the undersurface of the entry lens capsule. Now polishing the posterior capsule with hydrojet gently. Injecting viscoelastic to form the antechamber. Now I'm injecting this toric IOL inside the bag. So here I'm placing the lens a little bit off axis, 10 to 15 degree off axis before visco removal, so that I can bring it to the correct position after the visco has been removed. Forming the chamber, especially the main tunnel, removing the viscoelastics. One should go below the IOL to remove the viscoelastics behind, so as to prevent any IOL rotation in the postoperative period. As we know that the maximum rotation occurs within the first 1 to 2 hours after surgery. Removing viscoelastic behind the IOL. Removing the viscoelastics from the bag, and at the same time using the cannula to dial it in the correct position. Now the Sinski, I am doing a fine adjustment. As the actual IOL placement is 167 degree, I have kept it little off axis of 165 so that it will be exactly at the 167 degree. Forming the chamber, hydrating the side ports and the main tunnel. AC is well formed. Intracameral moxifloxacin also injected. Now you can see that the IOL is placed at